Good evening, everybody. I will be presenting a case today in neuro-ophthalmology. So chief complaints, a 20-year-old male came to our OPD with chief complaints of drooping of the left upper lid, binocular double vision, and outward deviation of the left eye for 7 months. History of present illness. So patient was apparently normal when he met with a road traffic accident while driving his bike. There was loss of consciousness for 1 day, bleeding from his ear and nose, and memory loss for 23 days. Patient was admitted in the ICU for 1 week and treated with oral steroids. The left eye upper lid drooping was complete immediately following the trauma and gradually improved. Now, double vision is present binocularly and intermittently in up and down gaze, and he has difficulty in moving his left eye inward. There's no history of diplopia in primary gaze. There's no history of diminution of vision. He does not have any difficulty in reading. There's also no history of diurnal variation of symptoms. There's no history of headache, nausea, vomiting, tinnitus, protrusion of the eye or chemosis. There's no history of weakness of limbs, tremors, ataxia. There's no history of weight loss, jaw claudication, scalp tenderness, fatigue.
So let's take each of the negative history. Okay, why does she ask for history of diplopia in primary case, Rudra? We are presenting a case of binocular diplopia, right? So why does it have to be a muscle entrapment to have diplopia in primary gaze? Okay, so this person doesn't have it, right? Does it make a difference in our management eventually? You all know the case is third nerve. How? Yeah, because a long-standing diplopia, right? So then you might want to think of prisms and all, but usually we do not give prisms if there is no diplopia in primary case. Okay. No decrease in vision. How does that history matter?
Ma'am, amblyopia can be a reason for
amblyopia. Will it have diplopia?
No, ma'am.
Why will it not have diplopia?
Ma'am,
in amblyopia, there's always suppression. Okay,
yes,
and only if you've had fusion and fusion is disrupted, only then can you have diplopia.
Yeah.
So amblyopia sets in before fusion. Okay, so those usually amblyopic patients do not develop diplopia. So why are we asking for decreased vision in this case? Please keep it relevant to this case.
There can be, because of mydriasis also, there can be a...
No, you're thinking too much in terms of third nerve, but traumatic optic neuropathy. Okay, any cause of decreased vision, maybe even cataract, traumatic cataract, any other cause of decreased vision. This patient doesn't have decreased vision. If he had very poor vision, he may not have had diplopia at all. That's another reason for not having diplopia in the presence of a manifest squint. Next, no history of difficulty in reading. Why, Divyansh?
Many traumatic mydriasis would cause difficulty in accommodation. So
right?
accommodation.
One is traumatic mydriasis, so the other one in this case is a nerve palsy. You're thinking in terms of a third nerve and all that. Okay, yes. Next, no history of diurnal variation of symptoms. Why is that history so important?
Myasthenia, to rule out myasthenia gravis.
Yes, because myasthenia mimics any kind of cranial nerve palsy. So you have to keep it in your differential. So there's no history of diurnal variation. Next, history of headache, nausea, etc.
Rise in IOP.
IOP or something else? ICP, right? Raised intracranial pressure. All the symptoms are like that. But the last two are not. Protrusion of eye and chemosis. What does that have to do in a case of nerve palsy? Okay, they are basically orbit symptoms. So it could be thyroid eye disease, it could be CC, that can present with any kind of nerve palsy. Okay, next. No history of weakness of limbs, tremors, etc.
Ma'am, syndromes, Weber
yes,
syndrome.
Different syndromes of third nerve. Next, history of weight loss, claudication, scalp tenderness.
Arthritis.
Giant cell arthritis. Can giant cell arthritis have ophthalmoplegia?
Yes.
Yes, it can. It doesn't have only arthritic ION, right? It also has ophthalmoplegia. Nice. And very basic question. How do you know? What is the very first question you ask when a patient comes to you with diplopia? Monocular, binocular. How do you know if it's monocular, binocular? After closing either eye. Okay, because if you close the eye with the monocular diplopia, he's going to say that it's no diplopia. Okay, Rahima, some causes of monocular diplopia. Monocular diplopia means you can relax because the cause is always intraocular. So what could they be? Go from front to back. Cornea? Steep astigmatism, severe astigmatism. Iris? Polychoria. Lens? Cataract, immature cataract, subluxated lens, subluxated IOL, anything like that. Retina? Any cause, retinal cause of monocular diplopia? Some kinds of ERM. Okay, fine. Binocular could be a CNS problem. So we're interested in binocular diplopia. Please carry on.
Past ocular history, there's no history of surgery or laser, no history of any systemic comorbidities, and no significant family history.
Laser, Bhavini? And what laser?
If he had any treatment in the past.
No, so you'll be very careful with negative history because they're going to catch you on all this. And it has to make sense, right? We can't have a blanket negative history for everything. So probably sometimes if you're very aggressive with your retinal PRPs or lattice barrages, you can hit the ciliary ganglion and produce a tonic pupil. So then you will have anisocoria. Okay. Glaucoma, those kind of lasers really in this case doesn't matter. Maybe uncontrolled diabetes if you're looking for PRP, things like that, yes. Okay. Carry on.
So general examination, patient is conscious, cooperative and moderately built, no abnormal head posture, no facial asymmetry.
Okay, stop there. Mridula, what are causes of AHP, anomalous head postures? So basically an acquired parietic squint. Next. Ptosis. Ptosis will have a chin up. Then? Torticollis, that's a neck posture itself, right? And? Nystagmus. Why nystagmus? Null point. Okay, so these are the causes. If someone asks you causes of AHP, these four: acquired parietic squint, torticollis, nystagmus, and ptosis. Okay. Always this keep in mind. I don't know how many of you got back to Meena with the slit lamp. She wanted this thing, right? Format of slit lamp examination and history taking and all that. So always start with the body, face, eye. Okay, for whatever case you're doing. Carry on.
Ocular exam, Hirschberg test, there was a left exotropia. Extraocular movements, right eye full and free and painless. Left eye elevation and depression was limited, -4, adduction -1, and abduction and intorsion was full and free and painless. On depression and adduction, there was a lid lag present, pseudo-Von sign, and there was narrowing of the palpebral fissure on abduction and widening on adduction, pseudo-Duane sign.
Okay, Bhavini, what do you mean when you say -1?
Like, ma'am, we can,
It is -2, -4.
based on how much of the cornea is visible when.
Okay, so if it is -1, that means the muscle achieves at least 75% of its motility. Okay, if it's -2, then 50%. -3, 25%. -4, it's not moving from its primary position at all. This is all quite subjective. So if you really want to be objective, what should you do? You should measure it with prisms. Okay, but we are in our OPD, we are pretty subjective, so we just do like this. In the exam, remember to say, there are some old timers who are going to be very particular when you say limitation and restriction. If so, better to stick with limitation. If you say the word restriction, they will assume you have done an FDT and your viva will go on that. Okay, yeah. Oh, she's already told off what those things are, but anyway, we'll come back to it later. Maybe carry on.
Yes, this is a video which will be showing us the extraocular movements and the signs.
Left side, right side, left side.
What is this showing?
Right side,
Which eye? Left eye. Pseudo-Duans.
इधर ऊपर नीचे देखिए.
That is lid lag. Don't use the word lid retraction because lid retraction is usually used in thyroid disease. So we stick to lid lag.
Left side.
The brain thinks the inferior rectus is firing, but actually the LPS is getting fired. Okay?
नीचे, right side नीचे, left side नीचे.
Always check for down gaze before you lift the lid first, because otherwise you will miss things like lid lag. The first time you ask the patient to look down, don't touch the eye. Second time you can lift it up. Otherwise you'll miss lid lag. So one sign is pseudo-Duans, other one is?
Okay. Right eye pupil size 3.5 millimeters, round, regular and reacting to light. The left eye size 6 millimeter, round, not reacting to light but reacting on convergence. Anisocoria is present, pseudo-Argyll-Robertson pupil present, and no reverse RAPD. Color vision checked with Ishihara pseudo-isochromatic charts, both eyes 21/21. Best corrected visual acuity was in the right eye 6.5 and N6 at 30 centimeter, and left eye 6.6, N18 at 20 centimeter. His cornea and facial sensation was intact.
Why are you asking about that facial sensation and cornea?
For 7th nerve and 5th nerve.
Nerves, to rule out multiple nerve involvement, right? And somebody in the audience, please tell me what is meant by that OS whole line, right? In one word. Light near dissociation. Excellent. Can you tell me some other conditions where you have light near dissociation? Yeah, syphilis is Argyll-Robertson comes in that. Sometimes bilateral optic neuropathy. Okay, they will not have RAPD because RAPD is relevant. Relative. Okay, carry
on. This video is to show anisocoria.
Which eye is the first most important thing in anisocoria is to find out which is the abnormal eye. Is the smaller pupil abnormal or the larger one? So left eye pupil is dilated.
Right side देखिए सर. सीधा. Right side देखिए.
Is this patient focusing at a distance target or a near target?
Right side back देखिए.
Looks like near, I think,
Mama,
because
They
मेरा
were
back.
trying, ma'am,
Yeah.
to make him
Right side.
focus on a near target, but it
Right
wasn't
side.
very clear.
and because he's developed aberrant regeneration, the pupil is reacting. In an
Right
acute
side
pupil
पूरा.
involving third nerve, the pupil will be fixed. It won't react.
सीधा.
Okay, we can move on.
अभी right side.
Slit lamp examination. So lid and adnexa, right eye normal, left eye mild ptosis was present, adnexa normal. Conjunctiva was normal and quiet in both eyes. Sclera was normal in both eyes. Cornea clear in both eyes. Anterior chamber, Van Herrick's reading 4 and quiet. And lens was clear in both eyes. Both eyes intraocular pressure by Goldman applanation tonometry at 10:30 am was 14 millimeter Hg.
Okay, Bhavini, if the patient has mild ptosis, are you looking at another kind of anisocoria?
Myasthenia gravis.
No. Here we know it's a third nerve, but suppose a patient comes to you with mild ptosis, you're looking at something at the pupils. Are you looking at a dilated pupil or a miotic pupil?
Horner's
Honor. So
syndrome.
it is going to be a miotic pupil. So
Miotic
whenever you
pupil.
have mild ptosis, always rule out miosis.
So ptosis evaluation, the severity of the ptosis was mild. Palpebral fissure height 9 in the right eye and 8 in the left eye. MRD1 was 4 in the right eye, left eye 3. MRD2 5 in the right eye and 5 in the left eye. Fatigability test was negative. LPS action was 15 in the right eye, 6 in the left eye. Lag ophthalmos and lid lag was present in the left eye. The marginal crease distance was 8 in both eyes. Bell's phenomena was good in the right eye, fair in the left eye. Marcus gun phenomena and Cogan's lip twitch was absent.
What's Marcus gun?
Like when on moving the jaw,
Hmm.
if there's any ptosis of the eye.
Ptosis or something else? The
blinking
lid
of the
opens
eye.
up.
Yeah, lid opens up, sorry.
Yeah, on eating or chewing or something, the lid opens.
Hmm.
Okay, and Kogan twitch we anyway said. Okay.
And Hertel's was 16 by 16 and both eyes orbital margins were intact.
Any first year, what's that number in the bracket? 100 for Hertel? Tell, be bold. There's no, it's okay, right? What is it? What is 100?
Base.
Yes. And why is it important to have that? Yes. Okay. So all of you go and read exophthalmometry, okay? First years. Yeah.
Squint evaluation, Hirschberg test left exotropia, cover test for distance and near left exotropia with 16 prism diopters basin for distance and 20 prism diopters basin for near. The force duction test in the left eye for superior rectus and inferior rectus negative. Worth 4 Tor test done with red filter in front of right eye and green filter in front of left eye for distance and near. Fusion to cross diplopia was present.
How did you do the FDT for superior and inferior rectus? Where did you hold your forceps?
Ma'am, we will be like in the direction of action of the paretic muscle. We will be holding it, the conjunctiva with the forceps and then moving it to the direction. No. We don't ask the patient to move the eye. We move the eye.
Tell me the interpretation of Worth 4 dot test. Have you seen the Worth 4 dot? Is there in all the rooms, right? Anybody quickly? No, we'll ask. This side is quiet. The girls are quiet. Tell. Normally, what should a patient see? 2 red and 2 green. And the patient is wearing red-green glasses. By convention, red before the right eye, green before the left. What are those glasses known as? Red-green glass. Somebody's name.
Armstrong.
Armstrong. Yeah, Armstrong. Yeah. Thanks to Padma. Yeah. Okay, then tell. If somebody is seeing 2 red dots, what does it mean? Left suppression. If they're seeing 3 green dots? Okay. And if they're seeing 5 dots?
Diplopia.
That's diplopia. If they have a manifest squint but are seeing only 4 dots? ARC, anomalous retinal correspondence. That's all. Just need to know these 5 points. Okay? Carry on.
So this is the diplopia charting which was done for the patient, which is showing cross diplopia. And maximum horizontal and vertical diplopia was noted in dextrodepression gaze.
Yeah, we'll move on. What is the purpose of the red-green glass?
Dissociate the
To dissociate
images.
binocularity. Okay.
And
I
this,
absolutely hate charting, but anyway, carry on.
the left eye was showing underaction of the muscles supplied by the third nerve, and right eye showed overaction of the yoke muscles.
Okay.
So fundus examination, dilated retina exam by 20 diopters and confirmed by 90D. Media was clear in both eyes. Disc was pink in color in both eyes. Size moderate. CDR 0.4 with a healthy neuroretinal rim. Peripapillary retinal nerve fiber layer was normal with dichomatously branching vessels. Posterior pole was normal. Right eye periphery retina was attached. Left eye, few vitreous floaters were present. Summary, 20-year-old male, drooping of left upper lid, binocular double vision, outward deviation of left eye post-trauma, Hirschberg and cover test for distance and near left exotropia, left eye extraocular muscles, elevation, depression, and adduction limited. Left eye pupil is mid-dilated, anisocoria and pseudo-Argyll-Robertson pupil present. Left eye has third nerve palsy with signs of aberrant regeneration. Fundus left eye has few vitreous floaters.
Okay, so at this point, what is the probable diagnosis? Left eye, right? So you have to say left eye isolated. You have put a diagnosis next.
Yes,
Yeah,
ma'am.
put that. It's going to be your left eye isolated pupil involving third nerve palsy with aberrant regeneration. Right eye is normal in this case, but if there is any symptom in the right eye like cataract and all, you have to tell that. Okay, use both eyes in your diagnosis. Okay.
The field test done for the patient.
Okay, so we'll wait here and this. How will you manage this case now? Patient has come to you with diplopia for so long, right? No, why you want to patch the eye for so long? For more than say years, suppose 2 years ago, we have not told you when the trauma was. Yes, one is a PRISM trial, okay, to confirm. Then if it is, to see if the diplopia disappears. Then, is there any other option? Yes, phenyl prisms, no, this is prisms, so different kinds of prisms. Then, would Botox work? It is an option. It's a temporary option. Where will you put Botox?
Lateral rectus.
Lateral rectus. Yeah. Okay. And otherwise, surgery. I think she'll discuss all those points later on as they go on, right? What is your imaging modality of choice? MRI brain with something else?
Angiogram.
MRI, you're assuming it's because of trauma. Could be anything, right? So when you have a pupil involvement, when you have a pupil involving third nerve, what are the conditions where you can get that? Or it can be an aneurysm. Where will the aneurysm be? At the junction of the posterior communicating artery and ICA. Okay. Then what else could it be? It could be trauma. Yes, some hematoma or something. Some SOL, it could be meningioma, anything like that. SOL could be meningioma or it could be aneurysm. Okay, so basically looking at an SOL, right? That is one. SOL is one, trauma is the other. Where else can you have a pupil involving third nerve? No. Yeah, but will they have aberrant regeneration? No. So where will you have a pupil involving third nerve with aberrant regeneration? Other causes, congenital third nerves. Okay, obviously this guy is not congenital. We still don't know whether he has an aneurysm. It could still be trauma. So we need to image him for that. Okay. Microvascular third nerves, yes, 20% of them do have pupil involvement, but what's different? How is that anisocoria different from this anisocoria? Yes, it is never more than 2 millimeters, whereas here it will be more than 4 millimeters at least, and the pupil will be fixed and dilated in proper pupil involving third nerves. In ischemic third nerves, part of the pupil will react, but you will still follow up the patient very closely. Okay, fine. What percent of vasculopathic third nerves develop aberrant regeneration? 0. None of them. What percentage of myasthenia has pupil involvement? 0. So if this has pupil involvement, there's no need to do an eyes test at all. Okay.
The MRI brain at presentation showed left subacute resolving hemorrhage, and there was a longitudinal fracture involving the left temporal bone. The orbits and optic nerve were normal. And the most recent MRI brain and orbit showed there was no significant abnormality in the brain parenchyma or the orbit, and the MR angiogram was also normal. Causes of pupil involving third nerve palsy, aneurysm of the posterior communicating artery at its junction with the internal carotid, which is called the rule of the pupil. And this will be pupil involving and pain will often be present.
What is the rule of the pupil?
That all pupil involving third nerve palsies are caused by an aneurysm unless proved.
It's always
otherwise.
considered to be because of an aneurysm unless proved otherwise. Okay.
Or any space occupying lesion can also cause pupil involving third nerve palsy. In this, I think a pituitary adenoma is causing a third nerve palsy.
How can a pituitary adenoma cause a third nerve palsy? Where is the extension? The chiasm is somewhere, right?
Yeah.
Not near the third nerve, but
Basilar.
no. Cavernous sinus. Okay. When the pituitary adenoma starts having extensions going towards the cavernous sinus, you will develop a third nerve.
And secondary to trauma and microvascular causes, but in this case, we'll have relative or complete pupillary sparing.
Okay, so on this screen is one answer that I'm looking for. If the patient has got third nerve pupil involving palsy and papilledema, okay, what is the cause? Ankle herniation. Ankle herniation, okay? that can cause papilledema. Otherwise, normally with papilledema, what do we see here? Which palsy? 6th nerve as a false localizing sign, right? But this is in the serious case. So this is uncal herniation causing pupil involving third nerve palsy with papilledema. And that pupil, no, is called something. Hutchinson's pupil. It's another false localizing sign. Okay. Yeah, good.
So plan of action in this case, since patient is not complaining of any diplopia and primary gaze, there's nil squint intervention. But patient was keen on ptosis correction, so he's been advised left eye frontalis link surgery. And recent MRI brain was normal, so no neuro-ophthalmology contraindication for the ptosis correction.
Okay. One more condition, when the pituitary adenoma in that particular case is slowly extending to the cavernous sinus. But suppose the patient comes to you suddenly with vision loss and severe pain, pituitary apoplexy. Very nice. Very good. Okay. Is there something else beyond this or theory?
Thank you.
That's it. Okay. Very nice. Nice.